Good day. I am Daniela Meri Faye F. Dultra, and I will be discussing the myocardial infarction. So the myocardial infarction, also known as heart attack, it is caused by decreased or complete cessation of blood flow to a portion of the myocardium. So myocardial infarction may be silent and go undetected, or it could be a catastrophic event leading to a hemodynamic deterioration and sudden death. So myocardial infarction, necrosis, or death of the myocardial cell is a life-threatening event. So if circulation to the affected myocardium is not promptly restored, loss of functional myocardium affects the heart's ability to maintain effective cardiac output. So this may lead to cardiogenic shock or death. For the prevalence, heart disease remains the leading cause of the death in the United States. Of the major heart diseases, myocardial infarction or heart attack and other forms of ischemic heart disease cause the majority of the death. So the majority of death from MI occur during the initial period after symptoms begin, approximately 60% within the first hour and 40% prior to hospitalization. So the risk factors for MI are those for coronary heart disease, their gender, age, heredity, race, smoking, obesity, hyperlipidemia, hypertension, diabetes, sedentary lifestyle, diet, and others. The clinical manifestation of myocardial infarction. First, we have chest pain, tachycardia and tachypnea, anxiety, sweating, nausea or vomiting, then dyspnea and shortness of breath, palpitation, diaphoresis, cold mottled skin, hypertension or hypotension, and decreased level of consciousness. So pain is a classic manifestation of MI. So chest pain is due to MI is more severe than anginal pain. So the onset of pain is sudden and usually is not associated with activity. In fact, most MIs occur in the early morning. So chest pain may be described as crushing and severe, as a pressure, heavy or squeezing sensation, or as chest tightness or burning. So the pain often begins in the center of the chest and may radiate to the shoulder, neck, jaw, or arms. It lasts more than 15 to 20 minutes. So for complications of myocardial infarction, we have the most frequent complication of MI is the disturbances or irregularities of heart rhythm, or also known as dysrhythmias. So then we have the cardiogenic shock. It is an impaired tissue perfusion due to pump failure, results when functioning myocardial muscle mass decreases by more than 40%. Then we have the pericarditis, the inflammation of the pericardial tissue surrounding the heart. So pericarditis causes chest pain, like aching, sharp, and stabbing. Then we have the ventricular septal defect, the cardiac tamponade, so heart that has so much fluid around it that it can't pump enough blood. So the force of this fluid make it hard for your heart to do its job. Then congestive heart failure, the heart doesn't pump blood as efficient as it should. Heart is a muscular organ and its job is to pump blood around the body, providing cells with the oxygen they need to survive. So the constant pumping action is produced by heart muscles in the wall of the heart. So the main pumping chamber of your heart is the left ventricle. When your left ventricle contracts, it sends oxygen-rich blood to your body to a large artery called the aorta. Connected to the aorta are small arteries called coronary arteries. So blood flows from the aorta through the coronary arteries to supply your heart muscle with oxygen and nutrients. So we come now to the pathophysiology of the myocardial infarction. So the atherosclerosis, it is a lipids accumulate in the intimal layer of the arteries. So fibroblasts in the area respond by producing collagen and smooth muscle cells proliferation, together forming a complex lesion called plaque. So plaque is consists of cholesterol, triglycerides, phospholipids, collagen, and smooth muscle cells. So this atherosclerosis causes obstruction, which limits blood supply. Then we have the arterial spasm. So this can be from drug use like cocaine and uncontrolled hypertension. So this causes the coronary artery spasm to constrict and then resulting to sudden reversible obstruction. Then for the atherosclerosis plus plaque split plus thrombus, So when plaque breaks open, it causes a blood clot to form inside the artery. So when the atherosclerosis lesion ruptures or ulcerates, substances are released that stimulates platelet aggregation, thrombin generation, and local vasomotor tone. As a result, the vessel constrict and thrombus or clot forms, occluding the vessel and interrupting blood flow to the myocardium distal to the obstruction. So it causes this atherosclerosis plus plaque split plus thrombus causes occlusion. So this obstruction, sudden reversible obstruction, occlusion, resulting to ischemia. So this is the decreased blood flow and oxygen to the heart muscle. So myocardial cell become ischemic when the oxygen is inadequate to meet the metabolic demand. So with prolonged ischemia lasting for more than 20 to 45 minutes, it causes hypoxia, resulting to hypoxia. So because myocardial oxygen needs are greater than partially occluded vessels can supply, myocardial cells become ischemic and shift to anaerobic metabolism, produces lactic acid that stimulates nerve ending in the muscle causing pain. So ischemia causes hypoxia resulting to reduced oxygen demand, and then reduces oxygen demand causes angina, which is the chest pain. Then it usually takes about 20 minutes of the artery to be blocked for the tissue to begin to infarct or to die. So this oxygen demand causes thrombolysis. So high risk drugs that causes blow up all this cloth, which damage the lungs. So thrombolysis causes permanent thrombus resulting to necrosis, which is the death tissue in the heart that causes myocardial infarction. So we will come now to the laboratory and diagnostic test. First, for the laboratory test, we have the creatine kinase. It is an important enzyme for cellular function found principally in cardiac and skeletal muscle and in the brain. So the CK level correlates with the size of the infarction. So the greater the amount of infarcted tissue, the higher the serum CK level. So we have here the normal creatine kinase result. For male, we have 12 to 80 unit per liter, and for female, we have 10 to 70 unit per liter. Then we have here the CKMB, also called as MB bonds. So it is a subset of CK specific to cardiac muscle. So this isoenzyme of CK is considered the most sensitive indicator of MI. So elevated CKMB greater than 5% is considered a positive indicator of MI. So the normal CKMB is 0% to 3% of total CK. Then we have here the cardiac muscle troponins. So these are proteins released during myocardial infarction that are sensitive indicators of myocardial damage. Then the myoglobulin, it is the one of the first cardiac markers to be detectable in the blood after an MI. So it is released within a few hours of symptom onset. Then for the complete blood counts, CBC shows an elevated WBC count due to inflammation of the injured myocardium. For imaging tests, we have electrocardiogram, echocardiogram, radionuclide, then the hemodynamic monitoring. So for the electrocardiogram, it reflects changes in conduction due to myocardial ischemia and necrosis. So classic ECG changes seen in MI includes T waves inversion, ST segment elevation, and the formation of the Q wave. So ischemic changes in the heart are seen as depression of the ST segment or inversion of the T wave. With myocardial injury, elevation of the ST segment occur. Then significant Q wave development indicates a transmural or full thickness infarction. So the myocardial damage can be localized using the 12-lead ECG. Then we have the echocardiogram. It is done to evaluate the cardiac wall motion and the right ventricular function. Then for the radionuclide, It is done to evaluate the myocardial perfusion. Then for the hemodynamic monitoring, it may be initiated when MI significantly affects cardiac output and hemodynamic status. So for the surgical procedure, we have the revascularization procedure, intra-aortic balloon pump, ventricular assist devices, and bypass surgery. For the medical management of myocardial infarction, we have aspirin. So it is a platelet inhibitor. It is now considered as essential part of treating the MI. Then we have the analgesia. So it is a pain relief. It is vital in treating the patient with MI. So pain stimulates the sympathetic nervous system, increasing the heart rate and blood pressure, and in turn myocardial workload. So we have the sublingual and the intravenous nitroglycerin. So it is a peripheral and arterial vasodilator that reduces afterload. So it dilates coronary arteries and collateral channels in the heart and increasing coronary blood flow to save myocardial tissue at risk. Then we have the fibrinolytic therapy. So it is a drug that dissolve or break up blood clot. So it is a first-line drug used to treat acute MI when access to cardiac catheterization lab for revascularization procedure is not immediately available. Then we have the antidysrhythmic medications. It used as needed to treat dysrhythmias. So they also may be given prophylactically to prevent dysrhythmias. Then we have the other medications. We have here the beta blocker. It reduces pain, limit infarct size, and decrease the incidence of serious ventricular dysrhythmias. Then, these drugs decrease the heart rate, reducing cardiac work and myocardial oxygen demand. So, initial dose are given intravenously. Then we have the angiotensin converting enzyme or ACE. So inhibitors are also it also reduce mortality associated with MI. So this drug reduce ventricular remodeling following an MI, reducing the risk for subsequent heart failure. They also may reduce the risk for reinfarction. Then we have the anticoagulants and antiplatelet medications often are prescribed to maintain coronary artery patency following thrombolysis or revascularization procedure. So for the nursing management, we have to administer oxygen along with medication therapy to assist with relief of symptoms. Then encourage bed rest with the backrest elevated to help decrease chest discomfort and dyspnea. Then encourage changing of position frequently to help keep fluid from pooling in the bases of the lungs. Then check skin, temperature, and peripheral pulses frequently to monitor tissue perfusion. Then provide information in an honest and supportive manner. Then monitor the patient closely for changes in cardiac rhythm and rate, heart sounds, blood pressure, chest pain, respiratory status, urinary output, changes in skin color, and laboratory values. For the prognosis, a person who has had a myocardial infarction is at risk of experiencing further cardiovascular events. In the initial 30 days following an MI, mortality result from conditions like cardiogenic shock, sudden cardiac death, heart failure, mechanical complication in the heart, and another MI episode. However, due to recent advancement in reperfusion procedures, in hospital death rate has decreased from 5.3% to 3.8%. So the primary aim of this reperfusion intervention is to minimize the extent of permanent damage to the heart muscle necrosis and the formation of scar tissue.